Good afternoon, ladies and gentlemen. This is my great pleasure to be here in the IEEE and so many talent engineers among me. And I'm going to present the clinical study on the renal transplantation. Title of my talk is Ultrasound Strain Relaxation Time Ratio, a quantitative marker in assessment of cortical edema in renal allografts. This is a collaboration research between Weill Cornell Medical College and the University of Michigan. As you know, renal transplantation is the best treatment for the patient with end-stage renal disease. In the United States, there are more than a million people waiting for kidney transplants. Only 17,000 kidney transplants took place in 2014 because of a severe organ shortage. On average, 3,000 new patients are added to kidney waiting list. 360 patients die while waiting for a kidney transplant every month. Therefore, it is very important to detect and treat early renal transplant rejection in post-transplantation management in order to prolong transplant kidney function. Alternatively, it's going to reduce organ shortage. Rejection is a leading cause of cortical fibrosis and transplant kidney dysfunction. In the diagnosis, kidney biopsy is a golden standard. However, it is very invasive with complications and high cost. Biochemical tests and conventional ultrasound imaging are insensitive in detecting rejection. So a non-invasive and quantitative technique is needed for monitoring transplant kidney rejection. Hypothesis. Main pathology of renal transplant rejection is cortical edema with increasing interstitial fluid and changing cortical tissue mechanical behavior. And the ultrasound strain imaging is capable of assessing biological tissue mechanical behavior. So the hypothesis of this study was to assess the capability of ultrasound strain imaging in evaluating biochemical behavior of a transplant kidney cortical edema associated with rejection. Study was approved by IRB at Weill Cornell Medical College. All subjects provided informed consent. Initially, we enrolled 21 renal transplant recipients who underwent ultrasound-guided kidney biopsy. In the study, we included 16 patients because those patients had the same cortical fibrosis that's less than 5%. Based on BEF score for renal parenchyma inflammation and edema, those 16 patients were divided into two groups. One's low grade, less than 25% cortical edema, the other one, high grade, greater than 26% cortical edema, and 8 patients in each group. Then freehand compression was performed on each patient in supine position. We used a curvilinear array transducer. That's an IQ Sound Sequoia. It's a pretty old machine, but because we use that machine for biopsy, at the same time use the machine to obtain the compression sequence. We use a curvilinear transducer to produce a gentle and a constant push on lower abdomen and the underlying transplanted kidney before the kidney biopsy. We used a 3-second cycle Sidney loop to capture pre, during, and post-push reference images for speckle tracking. speckle tracking was used to estimate the tissue strain. And we use the speckle tracking software, the Echo Insight from Epsilon Imaging. And the tissue strain displayed on the strain graph. Let me show this is how we measured to do the tissue strain estimation. The image is a longitudinal section of a transplant kidney. And the region of interest is a cortex that is 10 millimeters axial distance from kidney capsule to kidney collecting system. And the reference tissue is a 10 centimeters axial distance between the anterior abdominal wall to the pelvic muscles. You see the both lines because we measured twice, and the reference strains and the cortical strains. Strain curve. The strain curve, this is a strain curve. It starts at the zero strain. This is some people call the preloading condition. And the strain is increased following the push force until it reaches the maximum strain. And the strain relaxation begins upon the release the pressure on the soft tissue and the transplant kidney. Eventually, relaxation strain return back to this initial zero strain, and that is across the zero. We call the zero crossing. This is strain. The strain curve represents the strain history. The x-axis is the value of the strain. This is the time in seconds. From a strain curve, and then now we're talking about the strain relax time ratio. First, the cortical strain relaxation time. That is a time point when the cortical strain relaxation curve crosses zero. Reference strain relaxation time is at the time point when reference strain relaxation curve crosses zero. I'll show more images then after this. Strain relaxation time ratio is defined as a cortical strain relaxation time divided by reference strain relaxation time. As you know, all strain for clinical useful, we need because the force used for compression is not known, we need to perform strain normalization. Here's a case. This strain graph is from a patient with less than 25% cortical edema. You may, I'm sorry. I can go back. Okay. This is a graph from a patient with less than 25% cortical edema. This is reference strain. This is a cortical strain. Strain relaxation time. This is a cortical strain relaxation time. Cross the zero in the return back to the cross zero ahead of a reference strain. So because the equation is a cortical strain time divided by the reference, that's why this is a less than 1. This is strain relaxation time ratio at this case is a less than 1. And next one, this graph, strain graph is from a patient with a greater than 26% cortical edema. The more edema in the renal cortex. You may see this one, cortical strain reduction time cross zero, followed means after reference strain reduction time. This is a greater than 1. The result, strain reduction time parameters in 16 patients. Between groups, the reference strain reduction time didn't show significant difference between lower and higher grade cortical edema. However, cortical strain reduction time showed significant difference between lower and high grade cortical edema. The p-value is 0.012. In addition, strain reduction time ratio show even highly significant between lower and higher grades of cortical edema. So you may note that ultrasound strain reduction time ratio of cortical reference tissue is higher in high grade than cortical edema than lower grade cortical edema. And then this technique has a high reliability and reproducibility. Area under RC curve is 1 in determining greater than 20%, that's a higher grade renal cortical edema. It's difficult to believe area under RC curve is 1, but that's our result from this small group of the population. Discussion. Value of a strain reduction time ratio is positively correlated with the severity of cortical edema. More interstitial fluid in the tissue, longer time strain reduction takes to interact zero crossing. Reference strain reduction time seems to be constant, so it is a perfect reference to normalize cortical strain reduction time. Compared with using cortical reduction time alone, strain reduction time ratio improves distinction between high and low grade cortical edema, like I showed before. However, study has limitations. Small size, sample size is small, and no force used in free hand compression, and it is a semi-quantitative assessment. Conclusion, our results suggest that the ultrasound strain imaging seems to be useful in monitoring renal cortical mechanical behavior associated with cortical edema. In patients with less than 5% cortical fibrosis, ultrasound strain reduction time ratio is higher in higher grade cortical edema. Further study in renal transplant with various degrees of cortical edema is warranted. Thank you for your attention.